Good afternoon, distinguished guests, colleagues, friends. On behalf of the organizing committee, I extend my very warm welcome to the Sino-International Dialogue on Bone and Soft Tissue Sarcoma Standard of Care. I'm Professor Xiaohui from Beijing Jishuitan Hospital, and I'm truly delighted to serve as your chair for today's section. We are exceptionally privileged to have with us Professor Sebastian Bauer from West German Cancer Center, University Hospital Essen, who will be joining me as our international co-chair. Professor Bauer holds the chair of Translation Oncology at Essen, where he also serves as the director of both the Sarcoma Center and the Translational Sarcoma Research Lab. He is also actively involved in numerous professional societies. Please join me in giving a warm welcome to Professor Bauer for his opening remarks.
Thank you, Professor Neo. It really is an honor and a pleasure to be part of this Sino-International Dialogue. It's also my honor to introduce to you Professor Loong from the Chinese University of Hong Kong. He is Associate Professor at the Department of Medical Oncology. He's also the Director of the Phase 1 Clinical Trial Unit, and he's also one of the leading experts in sarcoma worldwide. So really looking forward to hear your presentation of what's going on in the bone soft tissue sarcoma world.
Thank you very much, Professor Bauer and Professor Niu, and it's a pleasure for me to be able to give you some insights into some of the new abstracts that's being presented at ESMO 2025 pertaining to bone and soft tissue tumors. So these are my disclosures. And to begin with, I've separated the highlights into three main aspects. One is about novel therapeutics, which are potentially applicable to a broad range of sarcomas. Two, harnessing and enhancing established treatment paradigms. And third, there have been some interesting abstracts looking at biomarker enrichment strategies, which can potentially lead to better outcomes. So, the first topic first. And one of the key studies that's been presented at ESMO 2025 is this study by Professor Shen and colleagues on a drug known as legubicin versus doxorubicin in patients with advanced soft tissue sarcomas. Legubicin is a first-in-class albumin drug conjugate, which is activated by legumine, which is a protease highly expressed in a variety of cancers. It is stable and non-toxic when it's in its albumin conjugate state, and it's designed so that it has a very low systemic toxicity, i.e. the toxicities of, say, cardiac and hematological. At the same time, when this drug is actually present near the tumor with activation in the tumor microenvironment through the presence of the legumine in the tumor microenvironment, as well as the acidic pH, that is when the activation actually happens. In this phase 2/3 randomized study, essentially patients with unresectable, recurring, or metastatic soft tissue sarcomas were randomized on a 1-to-1 fashion between legubicin or the standard of care, which is doxorubicin, at the standard dose of 75 milligrams per meter squared. And the primary endpoint for this trial was progression-free survival, with the key secondary endpoints that we typically look at. Specifically, there are secondary endpoints on safety, as well as cardiac toxicity and other indicators. There was a total of 301 patients that were randomized into the study, including histologies such as undifferentiated pleomorphic sarcoma, liposarcoma, synovial sarcoma, leiomyosarcoma, as well as others. And the majority of the patients recruited into this trial was recruited as a first-line treatment. Interestingly, the translational research also looked at the legumine expression, and 10% of the patients had a strongly positive expression, 26.2% with weakly positive, and the remaining 64% or so were unknown. We're going to have to move on to the next slide. And this is the results really indicating both the progression-free survival, which was the primary endpoint, and on the right-hand side, the secondary endpoints, including overall survival. What you can see is the median progression-free survival was 10.4 months in the legubicin arm versus 4.9 months in the doxorubicin arm, with a hazard ratio of 0.5 and statistically significant. There was also improvement in the objective response rates and disease control rates in the patients who were treated in the investigational arm. Next slide. And the safety parameters is something that's extremely important, and certainly these two slides indicate to you the cardiac toxicity as well as other toxicities. In terms of treatment discontinuation because of cardiac toxicity, Only 1.9% of the patients in the lagibusin arm actually required a stoppage of treatment versus 43.8%. And the majority of reason why they had to have the stoppage of the treatment was because of elevated cardiac enzymes. There was also less hematological, GI toxicities, as well as less alopecia in the patients who were treated with lagibusin compared to doxorubicin. And then the next abstract I would like to present is the Artemis 002 study, which essentially is a B7H3 targeted antibody drug conjugate, which is fully humanized with a topo-1 inhibitor payload. In actual fact, B7H3 expression is actually quite well documented and well known in a variety of sarcomas. And on the right-hand side, it indicates, of course, the molecular structure of this particular compound. The Artemis 002 study is an open-label, multi-cohort phase 2 clinical trial where there are actually 3 specific cohorts. One cohort, which is cohort 1, is for relapse and refractory osteosarcomas in adults. The second cohort are for relapse and refractory sarcoma adult patients and not osteosarcoma. And specifically, there's actually a third cohort which are looking for adolescent osteosarcoma patients. And you can see here on the right-hand side, which indicates that in this particular presentation, 68 previously pre-treated both osteosarcoma and sarcoma patients were included in this cohort. The median prior lines of treatment included 3 prior lines for patients of osteosarcoma. Some actually had up to 8 lines of treatment, and in other sarcomas, 2 prior lines. And looking at the results here, this is the osteosarcoma group of patients. The objective response rate was documented at 20.8% in adult patients, and the median progression-free survival of 8.4 months. The median OS was not reached at the time of reporting. Interestingly enough, if you look at the survival curves, you also see that there seems to be a dose-response relationship. In patients who are treated with a higher dose, which is the 12 milligram per kilogram, there does seem to be better responses as well as better survival than the lower dose of 6 milligram per kilogram. In the soft tissue sarcomas, which was also used at 12 milligram per kilogram, the objective response rate was 23.1% and a good disease control rate of up to 92.3% of soft tissue sarcoma patients. The median progression-free survival was 9.4 months, and the median overall survival was 22.6 months. Now, looking at the safety profile, as well as subsequent next steps, you can see that the most common adverse events are hematological, and most of them actually resolves with dose hold and a dose reduction. There was one patient who had interstitial lung disease in this particular cohort, but it was only documented at grade 1. So overall, there are very clear, promising results, which provides additional treatment option in patients with osteosarcoma as well as other sarcomas. And in actual fact, a confirmatory phase 3 clinical trial in patients with relapsed refractory osteosarcoma is currently ongoing in China, and as well as the fact that it is being developed in early stages of clinical development globally by GSK. Another study I would like to highlight is the phase 2 study of chidalimide, which is a HTAC inhibitor, together with toripalimab, which is a monoclonal PD-1 antibody, which actually is a very interesting study that's come out of our colleagues within the mainland. Chidalimide is actually a HTAC inhibitor, and histone deacetylase amplification has actually been frequently found in sarcomas, especially in liposarcomas. This is an oral selective HTAC inhibitor addressing the subtypes of 1, 2, 3, and 10. And actually, preclinically, there have been good studies showing the fact that there is synergism together with immune checkpoint blockade. In this particular clinical trial, essentially 73 patients were enrolled into this trial, treated with a combination of the HTAC inhibitor together with toripalimab. And what you can see here on the next slide are the impressive results of this particular study. You can see that in patients who actually had well-diff or dedifferentiated liposarcoma, the objective response rate was 62.5% and a disease control rate of up to 95.8%. For the non-well-diff liposarcoma or the non-D-diff liposarcoma, the results were not as prominent. But overall, on the right-hand side, you can see the median progression-free survival of 7.1 months. And interestingly enough, the median overall survival of patients with well-diff or D-diff liposarcoma was at 36 months. Now, there's a very long interval between the median progression-free survival and median overall survival. So it begs to question whether or not the positive effects that we see may be because of the histone deacetylation, which may be causing some tumor microenvironment changes, leading to possibly good treatment outcomes in the subsequent line of treatment, or maybe the long half-life of toripalimab, also enhancing the synergistic effect of subsequent lines of treatment. I believe there will be more translational and experimental research in this particular question, and we look forward to seeing more results later on. Next slide, please. Now, another study, and certainly probably needs no introduction, was actually presented by our co-chair today, Professor Niu, which is the updated results of pimicotinib in TGCT. Essentially, patients with TGCT was randomized on a 2-to-1 fashion and a double-blinded format, either with to pimicotinib or as well as matched placebo. And subsequently, after 24 weeks of treatment, the label was open, and patients who were essentially randomized to placebo was actually then able to go on to pimicotinib. These results were actually previously presented at ASCO earlier this year, but at ESMO, the updated results of a longer follow-up of up to 14.3 months in its median was presented by Professor Niu. This shows essentially the results of Professor Niu's presentation, and what you can see here, the ones that's highlighted with a background of pink, is the longer term follow-up results. And you could see that there seems to be an increasing number of patients who have a deeper response as well as time has progressed in terms of treatment exposure. There's also improvements in the quality of life, or as well as the patient-reported outcome assessments on the right-hand side. Again, the longer duration that the patient is on, the longer follow-up, they seem to benefit for a deeper response and better symptom control. More importantly, there were no new safety signals that was identified in this longer follow-up. Now, moving on to the second topic, which is harnessing and enhancing established treatment paradigms, I've selected the EMU-SARC-2 study, which is the combination of sunitinib and nivolumab in patients with alveolar soft part sarcoma. We know that ASPS is an ultra-rare sarcoma subtype. It's resistant to cytotoxic chemotherapies, but it is sensitive to both anti-angiogenic TKIs as well as immune checkpoint inhibitors. The previous larger basket IMMUNO-SARC-1 master trial actually have shown that ASPS patients did benefit from this particular combination. So essentially the IMMUNO-SARC trial is a specific cohort of patients with ASPS who were initially treated with an induction phase of sunitinib single agent, followed by a maintenance phase of sunitinib and nivolumab. Essentially, in this particular small single-arm open-label study, we have essentially 18 patients who have been available for analysis. Now here is a snapshot of the results, and what you can see, the median progression-free survival is 13.1 months. Now, benchmark that, however, with the atezolizumab study, which is the phase 2 single-agent study published in the New England Journal of Medicine. Actually, the median progression-free survival at that time was 20.8 months. The objective response rate is 53%, and the clinical benefit rate at 88%. It does seem, however, that the depth of response, in terms of having a partial response as opposed to just stable disease, did impact the overall prognosis. Patients tend to have a longer duration of response in that particular situation, as well as patients who were previously untreated had a better outcome than patients who had prior systemic treatments. Now, another interesting aspect in terms of harnessing our currently established treatment is this study coming out of Poland, which is actually a combination of a recombinant lag-free protein together with pembrolizumab in neoadjuvant radiation prior to a surgical resection. We know the SARC-28 trial have shown the fact that upfront pembrolizumab together with radiation has shown improvements in patients with dedifferentiated liposarcoma as well as undifferentiated pleomorphic sarcoma. In this particular study, it is pretty much the same approach, but in combination with a soluble lag-free protein. The primary endpoint of this trial is actually looking at a translational aspect as opposed to just response, really looking at the percentage of tumor hyalinization and fibrosis, as well as whether or not they are able to go on to surgical resection. There are some key secondary endpoints as well. This is just a snapshot of the patients that were recruited, and really want to focus on the histological subtypes. So the SARC-28 trial limited to just undifferentiated pleomorphic sarcoma or dedifferentiated liposarcoma. In this particular study, in actual fact, the biggest or the highest number in terms of histology is actually myxofibrosarcoma, followed by UPS as well as DDLPS. There were also patients with myxoid liposarcoma, something for us to remember given the fact that these are actually very radiation sensitive, and therefore how much of this improvement is because of the fact that it's just radiation alone, or is there actually improvement with pembrolizumab or the recombinant lag-free protein. But overall, this swimmer's plot, the waterfall plot shows you the response, and on the right-hand side, it shows you the fact that 51.5% of patients actually had a good hyalinization as well as fibrosis in their tumors. Lastly, just to talk about some biomarker enrichment strategies for better outcomes. And the CONGRATS trial is the nivolumab plus or minus the use of relatlimab, which is an anti-LAG3 monoclonal antibody in patients who have tumors exhibiting tertiary lymphoid structures. We know that the immune checkpoint strategies have shown relatively limited efficacy in an unselected use in terms of sarcomas. We also know that prior investigation have shown that patients who have tumors with intratumoral tertiary lymphoid structures, they do tend to show a higher response to use of checkpoint inhibition. This particular clinical trial essentially is in patients who have proven tertiary lymphoid structures in their tumors, where they're randomized on a one-to-one fashion between the combination of nivolumab as well as relatlimab versus nivolumab alone. And on the right-hand side, it indicates the responses. Interestingly enough, the responses is more than what we'd expect in patients who are unselected, but the combination with relatlimab and nivolumab actually performed not as well as just nivolumab alone. But overall, this is actually an interesting strategy, and certainly, again, as a proof of concept study, maybe just the beginning of this particular approach, and again, we look forward to future investigations. So, and given the fact that this is just a small proof of concept study, what's probably more important is the translational research. And very interestingly, our colleagues have actually identified 6 responders as well as 6 non-responders and gone through a battery of translational research, including imaging-based single-cell transcriptomics, cluster annotation, gene expression comparison, as well as cell interactions. And they have identified these particular biomarkers on the right-hand side, which seems to be upregulated as well as upregulated in patients who were treated with good responses. And therefore, again, we need to have further biomarkers to really identify suitable patients for this approach. So overall, just to conclude, we've had some very significant advances in terms of novel therapeutics in this group of heterogeneous group of diseases. I think there's very clear emphasis on translational research as well as biomarker discovery in this year's ESMO. And we are really building on established approaches which have actually become the cornerstone for treatment development in sarcomas. There are a lot more other abstracts I have not had the time to cover, so do take the time to go through some of the publications as well as available posters that should be now available online, and really hopefully be able to learn more from this ESMO as well as future conferences. So thank you very much.
Thank you, Professor Loong, for your excellent and insightful presentation. Next, we are pleased to welcome Professor Hairong Xu, also from Beijing Jishuitan Hospital. Professor Xu is a leading expert with profound research experience in the basic and clinical aspects of bone and soft tissue sarcomas. He will now provide us with a comprehensive overview of the key point from the Chinese expert consensus on the clinical diagnosis and treatment of tenosynovial giant cell tumor, TGCT. Professor Xu, the floor is yours.
Okay. Thank you, Professor Niu. Hello, Professor Herbert Long, Professor César Serrano, Professor Feng Yi, Professor Hu Yongchen, Professor Yang Chen, Professor Zhou Yong. Good afternoon, ladies and gentlemen. It's truly my honor to present this 2025 Chinese expert consensus on the clinical diagnosis and treatment of TGCT. This work represents the collective effort of leading experts across China. And I'm here presenting it on behalf of the consensus committee, together with Professor Niu. Our goal in developing this consensus was to provide evidence-based and practical recommendations to guide the diagnosis, treatment, and long-term management of TGCT in China. This expert consensus was published last month in the Chinese Journal of Bone and Joint Surgery. It represents the first national expert consensus in China, focusing specifically on TGCT, and it marks an important milestone in standardizing the diagnosis and treatment of TGCT in China. This consensus was developed through the collaboration of a multidisciplinary team of 28 experts from more than 20 leading hospitals across China. The panel included specialists in orthopedic oncology, radiology, pathology, medical oncology, and etc., ensuring a comprehensive and balanced perspective throughout this process. I would like to express my sincere gratitude to all the participating experts for their valuable contributions and the commitment to improving the diagnosis and treatment of TGCT. About this consensus, why did we do it? And how did we do it? And what did we get? Let's dive in. First, let's look at why we needed to make this consensus in China. TGCT is very rare globally, and it's typically divided into two main subtypes, localized and diffuse. For localized TGCT, surgical removal is the main treatment, and in most cases, it's a simple and effective procedure. But for diffuse TGCT, things become much more complicated, often requiring multidisciplinary coordination. Here we have a 60-year-old woman presenting with a 10-year history of progressively swelling around the knee joint. We performed an open resection of the tumor, and you can see the tumor was very diffuse, involving multiple areas. It's kind of surgery surgeons really don't like, complex, tedious, and demanding. The good news is after 5 years, there was no recurrence. But the bad news is the knee developed degenerative arthritis, and the functional outcome was not ideal, you can see from the X-ray. But luckily for us, science had made great progress in this area. In 2006, a landmark study from Stanford University first identified the CSF1 collagen 6alpha3 gene fusion in TGCT. And this discovery revealed the key molecular mechanism driving this disease: the overexpression of CSF1 in small group of tumor cells. Following the discovery of this gene fusion, multiple CSF1 inhibitors have been developed and tested in TGCT over the past 2 decades. You can see here several key drugs, including pexidartinib, VIM, and PIMI. Most recently, on June 9, 2025, Merck submitted a marketing application for PIMI in China, marking an important step toward providing systemic treatment opinions for the patients with unresectable TGCT in China. So that's the background. Now let's take a look at how this consensus was developed. To develop this consensus, we carried out a comprehensive literature review in both Chinese and English database up to May 1st, 2025. We searched the CNKI, Wanfang, and the Chinese Medical Journal database, as well as the PubMed and Web of Science, etc. We included studies that focused on the diagnosis and treatment of TGCT, including original research, systemic reviews, meta-analysis, and published guidelines or even expert consensus that has been published. We excluded duplicate studies, letters, commentaries, and publications in language other than Chinese or English. To ensure transparency and consistency, we used a grade system to classify both strengths of recommendation and the level of evidence. A grade 1 recommendation indicates strong evidence that benefits outweigh the risks, while grade 2 means the balance is uncertain. For evidence, grade A represents high-quality studies, such as meta-analysis or randomized trials, and grade B or C reflects lower levels of evidence, including retrospective studies or expert opinions. From this photo, now you can see the moment when the consensus was finalized. All the experts raised their hands as agreement for certain consensus. The 3 experts on the bottom left are the chairman of the consensus meeting, who also serve as the corresponding authors of the published consensus: Professor Niu, Professor Ling, and Professor Chen. Now let's see what we got. In the end, the experts reached agreements on 13 consensus statements. Let's start with the consensus 1, which focuses on image evaluation. MRI remains the most important tool for diagnosing TGCT because it shows both the extent of the lesion and its relationship to nearby structures in great detail. Ultrasound is especially helpful for superficial lesions such as those in the hand or the foot. X-ray or CT serve as useful supplement, particularly for evaluating bone destruction or involvement. This recommendation has a grade 1 strength and level B evidence. Now it's a consensus, the second consensus for diagnosis. We recommend image-guided biopsy whenever it is possible. This approach improves the diagnostic accuracy and helps guide the treatment plan. In some selected cases, such as superficial, isolated, and small lesions that are completely resectable, a surgical excision biopsy can also be appropriate. This recommendation is rated as grade 1 with level B evidence. For TGCT is primary diagnosis through pathological histology, which remains the gold standard. When the diagnosis is uncertain or the morphology is atypical, IHS can provide valuable additional evidence. In some complex, ambiguous cases, molecular testing such as CS1 gene analysis may serve as a useful tool to confirm the diagnosis. This recommendation carries the highest level of evidence, grade 1, level A. For the treatment of TGCT, it should be individualized based on the patient's specific condition and the characteristic of the lesion. Management options include active surveillance, surgical resection, radiation therapy, and systemic drug therapy. For complex and recurrent cases, where the treatment decisions can be difficult, it is strongly recommended that a multidisciplinary team or MDT discuss and decide on the optimal treatment approach. This recommendation is grade 1, supported by level A evidence. For patients whose TGCT progressively very slowly or who have no symptoms or only mild discomfort, active surveillance should be considered the first-line strategy, especially when treatment may be ineffective or lead to serious adverse reactions. During the surveillance, patients should undergo regular image follow-up every 3 to 6 months to monitor disease changes and guide timely intervention if it is necessary. This recommendation is grade 1, supported by level B evidence. Surgical resection remains the treatment of choice for patients with nodular TGCT, also known as the localized type. But for diffuse TGCT, surgery is recommended when the patients have symptoms of functional impairment and when it is expected to provide meaningful benefit for the patient. This recommendation is grade 1, supported by level B evidence. So for both nodular and diffuse TGCT, open surgical resection is recommended to achieve maximal and complete tumor removal, which remains the cornerstone of effective treatment. But in select cases, especially when the tumor is within the anterior joint capsule of the knee, arthroscopic surgery can be considered as an alternative approach. However, it is very, very important to notice that the recurrence rate after arthroscopy is generally higher than that of the open surgery. And this recommendation are graded as grade 1, but level A for open surgery and grade 2, level B for arthroscopy. So in cases of TGCT with a cartilage or bone reconstruction, the recommended approach is to curettage the tumor and perform bone grafting to restore the structural integrity. When the joint is severely damaged, it cannot be preserved. Arthrodesis or joint replacement surgery should be considered to maintain stability and function. This recommendation is grade 1 with level B evidence. For patients with TGCT have severe joint destruction, the significant functional disability, joint replacement surgery can be considered as a reconstruction option. But it is very crucial to completely remove all the tumor tissues and the synovium to minimize the risk of recurrence during this kind of procedure. And this recommendation is grade 1, supported by level B evidence. For the management of complex extensive TGCT, when the TGCT involves critical neovascular structures, so we need to make complete resection. It is impossible. When this kind of situation happens, debulking surgery is recommended, followed by systemic adjuvant therapy to control the residual disease. In rare and severe cases, if expected post-operative function would be poor, then with amputation may be considered after MDT discussion confirmation. And this recommendation are grade 1, supported by level C evidence. For now, there is insufficient evidence to recommend radiation therapy as a standard treatment for TGCT. However, in selected cases, especially when the completely surgical resection is difficult, radiation therapy can be used as an adjuvant therapy to help reduce the risk of recurrence. This consensus carries a grade 2 recommendation supported by level B evidence. For patients with unresectable TGCT, treatment with CSF1 or CSF1R pathway inhibitors is strongly recommended. These targeted agents can effectively suppress tumor activity, relieve symptoms, and improve joint function in patients who are not suitable for surgery. As you can see in this slide from Dr. Nicholas' presentation at this ASCO meeting, he highlighted that in the MANOVA study, PIMI demonstrated excellent response rate and the lowest incidence of adverse effects, making it the best in its class. And this recommendation carries the highest level of evidence, grade 1, level A. The long-term management of TGCT should follow a chronic disease model. It is important to formulate an individualized treatment plan, evaluate the outcome, and adjust the drug when it is necessary. Management should also include monitoring for adverse drug reactions, providing rehabilitation guidance, and ensure regular follow-up to detect recurrence or progression at an early stage. This is grade 1 recommendation supported by level C evidence. Although this consensus summarizes our current understanding of TGCT, there are still many issues to explore. We truly look forward to your feedback and discussion to make this work even better. Thank you again for your time and participation. Thank you.
It's now lead us to our intensive discussion section where fortunate to be joined by esteemed panel, Professor Bauer, Professor Loong, Professor Vincenzi, Professor Serrano, Professor Hairong, Professor Feng, Professor Hu, Professor Yang, and Professor Zhou. So would you give the comment first?
Yeah.
Okay,
sure.
we were gonna catch. Yeah, here. Okay, so we got the 3 questions.
All right. So maybe I'll start off the discussion. What my take home from this year's ESMO was in terms of the key advances. I think there are 2 main themes that I would like to highlight. One is that we as medical oncologists come into play in an era of treating patients which typically would have been your domain. So that comprises of tumors that are locally aggressive, but have for many decades been your duty to treat patients, that is desmoids and that is tenosynovial giant cell tumors. And it's quite challenging, in my view, also for us as a medical oncology community, that we have to make decisions on treatments in patients who do not die of their disease. So it's not fatal. So all of a sudden, risk-benefit ratios change. That's something that I'm really looking forward to learn about and how we deal with this. It's also a testament to the benefit of research. So all these new treatments are a result of understanding the disease. In the context of tenosynovial giant cell tumors, it's basically the discovery of the fusion for CSF1. But it will be also interesting to know what your role is going to be in the future as orthopedic surgeons. So first of all, I think it's great news how much innovation has come to the field. If we start with TGCT, for example, we have several drugs in clinical development, several drugs entering basically the approval status or being approved already, and it now hits the practice test. So I'm really interested how that is going to change for example, the aggressiveness of surgery. I can speak for our center. Our orthopedic surgeons have a bit of a sigh of relief. They are not big fans of the surgery in the large joints for TGCT because of the morbidity of surgery. So it's going to be interesting how this changes the frequency of surgery and how long patients will be treated. So that is something that I'm excited about, to see various new drugs likely being available to the community. The second topic is immunotherapy. It's something that we discussed on Sunday during the preferred paper session. Immunotherapy is something that, for some reason, we are still waiting for a breakthrough of being able to providing it to our patients. So far, we have very narrow indications where only some of us can treat patients, like alveolar soft part sarcoma. Professor Loong has also presented some abstract on ASPS patient with a combination that is not very commonly used so far. We have scalp angiosarcoma who can benefit. But again, it's very difficult to get those drugs approved when there are so few patients, and it's very difficult to randomize in these ultra rare indications. But on the other hand, we all meet these patients. Once in a while, we meet patients with these exceptional responses. So that is something that we as a community definitely need to think about, what kind of trial formats will be needed to get an approval, even if it is based on an academic trial, to make sure that every sarcoma patient has a chance who has a reasonable likelihood of benefiting.
Professor Serrano.
Yes, hi everyone. So hello from Spain. I couldn't make this trip to ESMO this year, but just wanted to highlight a bit some of what I think that are the main highlights of this ESMO that actually Professor Loong mentioned all of them. So from regarding what's been said in ESMO this year, or what we've been learning from ESMO this year. In one side, I think that we've discovered new molecules that we knew that they were in sarcomas, but that they may play a very molecular and biological function because they have been successful trials targeting them. So this is the case, for instance, of B7H3 with this Artemis 002 trial that for the first time is showing such a promising data on how targeting this specific molecule is giving some remarkable activity in several sarcoma subtypes. So I think that is, even it's a phase 2, the data is preliminary, of course, but if it's worth pursuing because this is so novel in the field, and I think it's one of the remarks from this ESMO, and that's why I mean, they got the to go to the preferred paper section. The other novelty, I mean, this is an oldie, okay? So HDACs have been forever basically in the cancer field, but this new way of likely inhibit HDACs in sarcomas in combination, of course, with toripalimab is truly interesting. Again, this is a single-arm phase 2 trial, but already the activity, and especially in a sarcoma subtype that like well deep liposarcoma that we traditionally don't have enough response rates, and they truly need response rates because of the bulky disease and the need for surgeries, and also what Professor Loong mentioned as well about how this treatment, this acetylase of likely relevant genes for the disease gives this long overall survival and merits this merits, of course, to be explored further. Okay, so for me these are two novelties that I really love them, and then we just can maybe discuss very briefly two targets that we know that they work. So one will be doxorubicin. So we know that doxorubicin is very important for sarcomas, but the way of how legubicin develops doxorubicin to the patients is truly remarkable. And this is a phase 3 trial already, phase 2, phase 3 trial. So the data is truly encouraging, truly remarkable, that would merit to move it on. And also I like a lot the part of the lower toxicity. I mean, this is relevant. We always think of alopecia as something mild for patients, but that's important for them beyond, the cardiac toxicity that actually the results are remarkable. And of course, the last trial to highlight that everyone knows is about pimicotinib, a trial that I've been fortunate to be involved in this worldwide collaboration that we need them to gather representation from many areas of the world. And the data is consistent, the data is very solid, and the response rate and activity is increasing. So for me, these were the highlights and why I like these 4 trials quite a lot. This goes in part with the pimicotinib, with the how we treat the TGCT. I mean, I thank so much Professor Xu for your presentation. It's very enlightening and I enjoyed it a lot. These consensus are very necessary because the landscape of the disease is going to change a lot. As Professor Bauer said at the beginning, my surgeons too, the surgeons that work at Vall, my hospital, they are relieved of not having to do or perform aggressive surgeries in this type of disease. And now they say, this is wonderful. We need to treat these patients in multidisciplinary teams, which is very important, but preferably handle them to the oncologist, which I think is going to change totally the landscape of how we understand these patients, how we treat these patients. And there will be a lot of debate that maybe you can take it. This is not a cancer as it can metastasize and kill a patient, but so we need to take care of how these patients, sometimes they want to manage this disease a little bit different. So we need to take care of this as well in our clinic dailies. And last but not least, I wanted to just touch very briefly the very last point of the discussion about these connections that we need between China, Europe. I think they're very relevant. So China has catch up very, very rapidly. So it's impressive to see, for instance, this year in ESMO, but this year in ASCO, last year in ESMO, how many Chinese-driven trials are providing a lot of knowledge and very interesting drugs to the oncology landscape in sarcomas. China is a huge country, many people working very serious to develop drugs, and it's great to connect the expertise and maybe the capacity that we do have in Europe to establish networks for rare diseases, and also to people like Sebastian or myself to physician scientist profiles to have run own labs and try to understand better correlative science, to preclinical studies. I think that's part that we can provide for Europe these international collaborations that I foresee that they will be very fruitful in the future. And that was basically I wanted to say, and I hope that this can trigger the debate a little bit more.
Thank you, Professor Serrano. Professor Loong, would you give some comments for the question we have?
Sure. Thank you, Professor Niu. And again, thank you all colleagues for joining this panel discussion. I echo my colleagues. I think there have been very key significant advances in both bone and soft tissue tumors at this year's ESMO Congress. Each of the times, these trials, of course, we have small trials. We also have very big trials. But I think what's very important is all these trials do try to answer very important translational research questions. And many of the trials, even if they are, say, smaller scale in patient numbers, are also bolstered by a lot of translational research, which helps answer a lot of the scientific aspects. And I think there's a lot of collaboration that's in these trials where we could generate the evidence and then really move the landscape forward. I've highlighted the key trials, again, that was presented at this year's ESMO. There are still quite a few good posters, quite a few other trials. There are also some negative trials, which I think actually answered some very important questions, which I did not have the time to highlight. I do advise the audience to really just go back at the archives and take a look at those as well.
Thank you. Now it's Professor Vincenzi. It's your turn.
Okay. Yes. First, thank you for giving the opportunity to join this meeting today, to this webinar today. I have a couple of comments regarding the presentation about clinical trials in the area of soft tissue sarcomas and bone sarcomas. The first one is about legubulin. It is, of course, a very interesting trial. Again, it is something that we stress many times about the toxicity and the low activity of doxorubicin. But I want to stress again, due to the negativity of previous trial, that sometimes some biases can explain the apparently positive results. This is the case, for instance, of the high number of patients who discontinued doxorubicin due to cardiac toxicity. 43% is definitively higher than expected. And if the discontinuation was related to an increase of cardiac enzymes, probably this is something that should be of merit of further exploration. And in addition, actually, we know that specifically for some specific type of sarcomas, and namely for leiomyosarcoma, probably the first line could benefit of a combination of doxorubicin plus something else. First. The other aspect I want to stress is that, of course, is really fascinating the combination of immune checkpoint inhibitors plus radiotherapy. And again, the trials report usually the increased response rate. But again, radiotherapy alone can be associated with a tumor shrinkage, particularly significant. So it is very hard to address the positivity of the trial according to the response rates in this context, because some histologies may respond very, very well to radiotherapy alone. Moving to the consensus paper, congratulations. It is absolutely a great job. It is something that highlights, once again, if necessary, the need of a multidisciplinary approach in TGCT. It is really also fascinating to observe some discrepancies between the different areas of the world, because, for instance, radiotherapy is something that we do not propose as adjuvant treatment, neither as palliative treatment as well. And again, also the opportunity to prescribe some medical treatment actually in Europe is very, very limited to the regulatory constraints. So it is out of clinical trials, of course. But again, we are probably at the sunrise of a new era for the treatment of TGCT. And as Professor Serrano already addressed, it is absolutely important to try to make a unique effort to clarify not only the biology, because we made a lot of steps forward to better understand the biology of the disease, but in terms of clinical guidelines, it is probably a good idea to try to collect all the different experience, to try to do a worldwide effort to clarify all the different aspects of the clinical management of this rare disease.
Okay, thank you. So next should be Professor Hairong Xu on the net.
So thank you, Professor Liu. As a surgeon, I see from Professor Loong's presentation, I feel like the progress in this year's ESMO remains rather slow for me. I've been hoping to see some major breakthroughs. And so I have a question for Professor Loong. If you were to make a prediction, so where do you think going to be the most significant advances in osteosarcoma and soft tissue sarcoma are most likely to emerge in the soon future?
Yes, I think you're right. I think maybe from a surgical perspective, things have not moved on as quickly as you would like. At the same time, we are seeing a lot of drug development. I am quite impressed by the larger phase 2 and phase 3 clinical trials that's been presented at this year's ESMO. So the ligubicin, we know that doxorubicin is an important drug, but again, how do we overcome that toxicity? And I think finally we have a method of being able to do that. I would like to see this drug being developed outside of China as well. We need to make sure that we have international data. And I think at the same time, there's even a possibility of looking at combinational treatments now, given the fact that the safety profile of this particular compound may be quite acceptable. So I think with this solid evidence in mind, we can then possibly build up on it. Yeah.
Thanks for attending the discussion. I have a question ask the Professor Vincenzi. We just share the discussion about the Chinese expert in the TGCT. I'm curious for the European perspective. Would you like to talk about what is the biggest difference in the diagnosis and treatment for the type of the tumor among the different regions?
Mm-hmm. This is a really nice point because there is a big difference according to the different regions, actually. Probably you know that in Europe we did a great effort about identification of reference centers that must be approved by a system called EURACAN. And in the philosophical approach, according to the European agency, we should try to collect all the patients in these two reference centers. Unfortunately, this is not true for all the different regions. For instance, in Italy, we have a sort of gradient. Patients that are treated in the center in the south are treated in the reference centers up to 40% of cases, in the north part of Italy in a percentage higher than 80%. So this means that we have still a lot of patients that are treated out of reference centers. Unfortunately, this means that these patients do not benefit of a previous multidisciplinary discussion. And this is, of course, a limitation. And we see still patients that receive 1, 2, 3, 4, or even more surgical procedures that actually probably are not useful for the overall prognosis in terms of symptoms, mostly. And we have patients that receive aggressive surgery, even if they are asymptomatic. So the discrepant approach, it is something that we must try to approach and limit overall, and try also to make some awareness, because patients must be informed that actually we have also some alternatives to surgery.
Yeah, thank you very much.
Okay, thank you. No, thanks, Professor Hu. Okay, your microphone.
I'm so happy to listen to the report of Professor Hairong Xu. And this is the first time to heard about the consensus of the TGCT. And this is very helpful for the surgeon to make a decision for surgery or treatment. I have a suggestion for Professor Hairong Xu, and I hope you to invite some international expert and to improve your consensus. And you can publish this consensus in English, so you can have the improve the surgical level of the international. This is my suggestion. Thank you.
Okay, thank you.
Thank you.
Professor Yang.
I had attended these discussions. First, I should say congratulations on the Chinese concerns on TGCT, the series published. And second, I also should say congratulations on Professor Niu leading the couples and groups get so brilliant result on the TGCT, the clinical test result on TGCT. So just like you say, and as a result, so that we get so brilliant ORR rate on the TGCT, that means that many people can benefit from these medicines. So I got my insight on this. Whether we think the patient can get benefit in neoadjuvant on this kind of disease? So if we got that result like this one, I think this can be improved R0's resection rate and reduce the recurrence rate. How about, do you think about this one?
So it is absolutely an appropriate question, because as anticipated, we are in a new era, at the beginning of a new era, because the use of medical treatments was limited, actually, so far, to unresectable and definitively unresectable disease. So this means that the context, the concept of neoadjuvant was neglected so far. But actually, and this is probably a common experience, we are seeing actually some unexpected and deep response that can open new options, also the surgery option. So I believe that the neoadjuvant treatment could represent a new context to explore the activity of this specific new family of drugs.
Yes, yeah, that's great.
Yeah, and probably also a sandwich approach, neoadjuvant, surgery, surgical removal, and a sort of adjuvant treatment could be an option, because even if the orthopedic surgeons probably are in favor of a potential R0 resection, think that this disease could be radically resected is hard, at least in the idea of for the medical oncologists. So an adjuvant treatment could be also another part of the treatment that could be considered.
Yes. Okay.
Okay, thank you. So it's your turn.
Thank you. Good afternoon, everyone. It's a great honor to be here and to take part in the discussion. Here is my opinion. First, based on the Chinese experts' consensus and the maneuver study, I think the treatment strategy of TGCT is changing. The management is more feasible, should be from disease control to patient management, because with the CSF1R inhibitors, our goals have changed, and our long-term strategies must adapt. And this strategy is central to balancing the efficiency, the toxicity, the cost, and the quality of life. Second, the evolution of response criteria should be more comprehensive. I think the traditional RECIST criteria may not fully capture the benefit from the TGCT patients. Patients' reported outcomes such as pain scores, joint function, and the quality of life measures are become more critically important. And third, because the pre-treatment can shrink the tumor volume and potentially convert a major morbid resection into a more minimal functional preserving procedure. So I think should the patient take a surgery, and when should the surgery carry on? This requires the close collaboration between the surgeons and the oncologists to define the optimal time for interventions. I think there are so many questions need to be solved, but I believe we will figure out in the future with the leading of Professor Niu. I truly look forward to potential to the collaboration and the deeper exchange with everyone. Thank you.
Thank you. So time has indeed passed quickly, and this has been an immensely productive section. Let me once again express our gratitude to Professor Loong and for sharing the cutting-edge perspective from ESMO, and due to Professor Xu for his comprehensive exploration of the Chinese TGCT consensus. Many thanks also go to all our panelists for their engaging discussion and valuable insights. To bring our section to a close, I would like to invite Professor Loong and for the concluding remarks. Thank you.
Thank you, Professor Niu. And I think today we've had a very good discussion on some of the latest abstracts presented for ESMO, and then specifically also on the Chinese TGCT guidelines. And I think this really brings the entire sarcoma multidisciplinary approach to a nice full circle. I think we are very fortunate working in our group of diseases where there's frequent interaction between our systemic treatment experts, including medical oncologists, our radiation oncologists, as well as our surgeons. And out of all the different oncology subjects, I think sarcoma is one which is truly multidisciplinary. And today we've heard certainly from the Chinese TGCT guidelines where experts from around all these multidisciplinary disciplines were involved in its development. And I think the way that we are really treating TGCT can be a good model for some of the other diseases. Now, TGCT, we're very fortunate to know about CSF1, knowing of having a drug or a group of drugs now that could effectively target it. We're missing some of this knowledge for other types of sarcomas, but once we are able to crack that molecular aspect as well, I think us as a group of sarcoma experts, regardless of discipline, will be in a very good position because of the network, because of the friendship, and because of the multidisciplinary approach that we routinely do to really help improve the outcome of our patients. So again, it's a real pleasure for me to be part of this panel, and it's a real pleasure for me to meet all of you. And congratulations, everyone, and look forward to seeing you again.
Okay, congratulations. Okay.